Yeah, just a second.
Hi, everyone. Let's see. Can anyone hear me? Valerie, I can see you.
Yes.
Can you nod if you can hear me or give me a thumbs up?
We can hear you. I can hear you.
Awesome. Thank you, Doug. Thank you. Awesome. Welcome, everybody. We have an exciting day ahead of us. We have Mark Westerhaven, who's on his way out the door. He's getting ready to retire at the end of the month, so we're kind of getting him at the very end of his service. And he's a guru on spend downs for HCA. And then and Johnny Schultz. And then we're going to talk a little. Now, remember that everyone needs to remember that they don't know our D-SNP chart that we do and share that we use with the plan finder. So we'll have a little discussion about that after we're all done. And I'm gonna be repeating this because people are coming in, but it's going to be exciting. And I have a presentation to share with you guys that I'm going to share after. That's from HCA. It also includes spend downs for people with Magi, and for families with kids and things like that. But it has really good basic information on Medicare, which I was really happy to see. So, spend downs for people with Medicare. So hopefully it'll kind of clarify the things that were a little bit confusing with Angie last month. And hey, Shannon, if you see people popping into the lobby as we get going, do you mind admitting them? I think you can see them and admit them.
Yep, absolutely.
Thank you. We might also have Riva today, who is going to be replacing Mark in his position at HCA. So. And then next month, and clearly I'm just chatting now, but next month we're actually going to have Johnny come back, and then we're going to have Vanessa, and they're going to talk to us some more about D-SNPs and take all our answers. And we're going to talk more about the special. This month we're talking about kind of the D-SNP nuances with spend downs. Okay, and then next month we're going to talk about the special enrollment periods and changing from one to another, and some of those nuances, like if it's in alignment. What if someone wants a different D-SNP that's not in alignment because they don't use those benefits, right? Or those are the questions that I've been having and getting from people. And what is another one? Sometimes the better plan for them is the plan with the better flex card, right? So that's what they're going for, is more of the other benefits, or the plan for the gym that they want and a flex card or things like that. So we're going to talk about kind of those things next, the special enrollment periods a little bit more next month, and change the nuances of being able to change plans.
Hey, Noreen, could you answer a quick question before we get started?
You betcha.
I'm having a hard time understanding who qualifies for a Slim B plus.
Okay, so yeah, and actually I was going to kind of start with this.
Are you? You
Yeah.
can go first.
Yep, I'm going to talk about the pluses, because that's a point of confusion for everyone. So I had a talk this morning with my VC Eureka, and I'm going to try a new strategy for how to talk about it.
Okay, that'd be great. Thank you.
I practiced with Eureka to see if But thank you for bringing that up. That's a great, thank you for giving me that introduction to my.
We're working on the same wavelength.
Yes. Well, I think we all are, because, you know, we've just had so many things coming at us, right? And I mean, like, I just never cared about Heidi and Fighty and all that stuff, or it's like, and we didn't have all the different plans, and we just have a lot coming at us right now. So
It seems like the whole QMB plus, SLMB plus I don't remember seeing it until the
right.
last few months for some reason, and now it's everywhere. And yet, when I do some research, I found documents going back to 1999 explaining it.
Yep.
You know, so I thought, well, it's been around. I just haven't been as aware.
Yeah. So, you know what? We're at 11 o'clock. So let's just jump into that as we get started. First, I want to let everyone know, today we're going to have Mark Westerhaven, and I don't think he's here yet. And Johnny, who will be coming just a little bit later. And then maybe Reva from HCA coming in to talk to us about spend downs. And we're going to talk a little bit about D-SNPs with spend downs. And I sent them some questions. And then, but I thought we would just kind of start out talking about exactly what Scott just brought up, QMB plus and SLIMB plus. So the way that, and what I'm going to do is I'm going to open the rainbow chart for a visual kind of here. And if someone notices, Mark or Johnny coming in while we're doing this, just let me know. Okay. So we have our rainbow chart.
Noreen.
I'm sorry. Are you meant to be sharing your screen?
Right. I don't see.
There it is.
Oh, there it is.
There we go.
Yeah, it just takes a second.
Okay.
So we have our rainbow chart, right? And on our rainbow chart, we have 3 programs. We have the Medicaid program, right? And this is actually, just so you know, this is also the February CE. We have the Medicaid program up here, and then we have the Medicare savings programs, right, in the middle. And then we have extra help on the bottom. And you might have seen another one that has them broken up with the programs with the titles. And maybe I should actually pull that one up, but we're just going to stick with this one for now. So anyone who has, remember that these income limits are up to, right? So it's people who with income up to $963 that are fully dual eligible. Okay. So up to $963, they're going to get, they're categorically needy and they're full Medicaid. Anyone up to 1401 in income is eligible for QMB, and the Medicare Savings Program is actually what pays their Part B premium, not Medicaid. Okay. So someone who is eligible for Medicaid 963, they're also going to be QMB. Does that make sense to everyone?
Yes.
Okay. So, but they're QMB plus because they have that Medicaid. And so the way I think of it is the plus means plus Medicaid. Okay. And often when we're talking to people, they don't know their eligibility, but what they will say is things like, I have full Medicaid. And so then they don't realize that they also have QMB, right? Or they'll say, well, I don't have Medicaid, but the state pays my Part B premiums. And that would be just that might be just a standard QMB, because the determination is made on their income that they receive each month. We can have also people who are SLIMB eligible with income up to 1526 that are also eligible for Medicaid, because they're getting 1526 or less from Social Security, right? So they're SLIMB eligible. Let's say they're making $1,500, but they probably have long-term care assistance that's bringing their income down to a level that makes them eligible for Medicaid, because that's how that works. So that would be generally people who are SLMB plus, which we don't see much of, are people with long-term care assistance. Okay, hold on just a second, because my dog is going nuts, because I tried to put her in her little area and I need to let her out. You need to be a good girl. Okay? Be a good girl.
This is Charlie. Can I ask a question?
Yes.
I thought you just said that if somebody's making $1,500 a month, they can be on Medicaid.
Mm-hmm.
How is that possible?
Because they could have long-term care assistance that maybe probably $600 a month or more is going towards their long-term care costs, their housing costs. So their income is less than the 963. So they are on Medicaid.
Oh, so some forms of the assistance count against your income, essentially.
Yeah, they're expected to contribute towards the cost. And then the state pays less. Hi, Reva, welcome.
Okay.
Hello, thank
Yeah.
you.
Okay, so that's our plus.
Oh, yeah. Hi, this is Fiona. I just wanted to add a little something about that. I think the way I like to think of it is that if someone is approved for long-term care, Medicaid long-term care, the financial workers over at Home and Community Services take a look at their income and they do set aside money for caregiving services. So it's like a contribution towards their care, which reduces them. They always try to get them down to at least Quimby level so that they are eligible for more Medicaid benefits. So that's what so you'll have clients tell you, I have this income, but on the other hand, they're Quimby's, and that's usually a signal that they are in Medicaid long-term care because some money is being filtered over to their state caregiving, services. I hope just that's the way I think of it. It kind of helps me when I run into those clients.
Yeah.
Yeah.
Thank you. And I don't know about you, but most of the time what we hear is that people will say they have Medicaid, right? They'll say, oh, I have Medicaid. What they won't know is that people with Medicaid won't know that they're QMB also, right? Or people will say that they don't have Medicaid, but the state's paying their Part B premium. So
Hey,
there's
Noreen,
uh-huh.
just 1 second. The interpreter is online and they're wondering who they need to pin. Do we have?
That is for my volunteer, David, and he hasn't joined yet for some reason. I've sent him an email to ask where he is.
Okay.
I made sure he had the link earlier. I'm not quite sure what's happening. So I'm
Okay.
sorry, interpreter. When he joins, you will see his name is David Gallion.
Thanks. Also, Johnny is here.
Okay.
Chris,
One of the
sorry,
things I found, one of the things I found is they may have a piece of paper that has the S95 or S99 or the SO5 or whatever SO6 on it, and that would tell you which thing they're in.
Yeah, it's always great if they can bring their letters, right? With their eligibility on it. And Mark sent me a presentation today that kind of goes over spend down that has the letters that they get for that too. So, okay, Kim, you had your hand up?
Yes. So that's perfect segue. So that's what I was wondering is about the spend down. How does that tie into these plus programs, or does it tie in at all?
We're going to ask that of the experts who are going to be joining us shortly.
Okay, thank you.
All right, and Johnny's here. Reva's here, I think. Good, Mark.
Yeah, I'm here too.
Awesome, thank you. Eva, before we get into...
So I have a logistical question. I want to make sure that I understand that people who qualify for Medicaid are not automatically on Quimby. They have to apply for an MSP proactively.
My understanding is no, that they get both.
Oh, really? Because I've always had to apply.
I don't know, Eva. Let's ask one of the experts if they know.
Great, thank you.
Well, I think in most cases they should be The worker should see that and add the program, but yeah, I can't speak to it. It should be policy that they, look at the case holistically. If you're eligible for both, they process both.
So out here helping these clients, how do we find out whether we need to go through the application process? And by the way, I think that the reverse is also true. No, I know that the reverse is true. Just because they qualify for Quimby, even if their income would qualify them for full Medicaid, they might not be on full Medicaid unless they apply for it separate from their Quimby application.
Yeah, so depending on which application you're using, you can check both boxes.
Right, right.
Then a lot of times you're going to end up with a spin down that nobody wants too. So
right. Okay.
I know there's no easy answer there.
Thank you.
Okay, and Paul?
On their Medicaid cards, does it show that they're in QMB? And does it show that they're in QMB plus?
No, that is really only something that the provider's office can use to verify eligibility. So they don't have to type in something, they can just use the card, but it doesn't say it's really just no more than an ID card. And you actually have to look into the system to see what the eligibility is. Which none of us are going to have out in the field.
Right.
But you can check their eligibility using that HCA automated call system, correct?
True. Yeah.
Okay.
Yeah.
Could while you're with them, that would be a good solution.
And where we are, we can, because we're AAA, we can check. Staff can check.
Right.
Yeah. Okay.
Okay, so do we have any other questions about QMB plus and SLMB plus versus regular QMB and SLMB?
Yeah, plus should just mean that they're on a Medicaid program. And that would not include a spin down. Spin down is basically invisible until you meet spin down, and then it means something.
Yeah, I think that's really helpful to put it that way, that it's just kind of invisible, right?
Yeah.
So they might have their other eligibility, like if they're eligible for SLMB or QI1, and that would kind of be what's prominent until they meet their spend down, right?
Exactly.
Okay. So I sent you guys some questions. I think the first one was, let me get them open. I'm so sorry. Sorry, I've been out sick, so I'm a little bit behind the ball here.
The first one I see, go ahead, I'm sorry.
No, go ahead.
Well, the first one I see is how D-SNPs are different for those with spend downs versus standard full dual eligible or partial dual eligible individuals. So an individual who's on a spend down will will be able to join a partial dual eligible plan. The only difference is that what it's related to for their spend down would be whether or not or how much of their client responsibility or their beneficiary responsibility they will be billed for. So in theory, someone will join the partial dual D-SNP, and they have a 20% copay. That's their responsibility, unless they're a QMB, and then copays, coinsurance, and deductibles are picked up by the healthcare authority, except for some Part D copays. So that's basically what and Mark, you can correct me if I'm wrong, but in essence, when it comes to when they join a partial dual eligible plan, and they're on a partial dual D-SNP, then they would get all the benefits associated with joining that plan, and the plan is responsible for providing them all the benefits in that planned benefit package. It would just be dependent on when they meet spend down, their co-pays, deductibles, and other pieces are covered by the healthcare authority because then they shift into that plus category. But they would still remain on the partial dual plan. They're not going to switch plans between the full dual and the partial dual. They're on the partial dual plan that they signed up for because again, that will change quarter to quarter or every 6 months or annually, depending on what their review period is. But from their perspective, the planned benefit package is the same that they've joined for the year. And the only difference they'll see is whether or not they are receiving a bill for the services for their 20% patient responsibility. Does that make sense to folks? Because I want to make sure that I'm covering the intent of the question.
Yeah. That's one that everyone has really struggled with.
This is Charlie. I'm completely lost, but I'm new at this. But one of the questions I have is it clear anywhere when you look at dual plans or SNPs, I guess they're called SNPs, is it clear anywhere what the trigger level is for when someone can get on a SNP or not? I mean, do you have to be full Medicaid to be on it? Or you're talking about partial SNPs, so I don't understand that.
So there's two different plans in the state of Washington. We mandated that they have two different options. So they'll have one that's one that is for individuals who are full dual eligible, and those are folks that have Medicaid and Medicare. And so they're allowed to join the full dual eligible plan. And this is designed for folks that are QMB plus or SLMB plus or individuals that have both Medicare and Medicaid active. Now, we also have a partial dual plan, and partial duals are folks who are involved in the MSP plan. So they're an SLMB, they're a QMB, non-plus, they're a QIY, they're a QDWI. And so they may have a spend down associated with that will bring them into the plus category. But that would more than likely be if they are don't have any, if they're Medicare eligible and they are on a Medicaid and they're in the MSP plan, then they qualify for the partial dual eligible plan. Don, I see your hand up, so I want to make sure that you're still on mute.
Donna, you're still muted.
Last time nato pero plan લઈને રેઇનબો ચાર્ટમાંથી જોઈને બોલે છે.
Prakash and Aruna, could you mute until until it's your turn? Thank you. Donna, we're going to come back to you. We're going to let you try to get unmuted, and we're going to come back to you.
How does consumer know that if they are dual eligible or partial dual eligible? I think the consumer education is just as important as we help them. And what are the difference in services of the two plans?
Sorry, I'm trying to make sure I capture that because again, I think that's more for in terms of how a client is able to determine what Medicaid coverage they have. So if a client is full dual, there should be some level of knowledge in terms of what Medicaid is going to pick up for their costs. Mark, do you cover that?
Well, we just do eligibility, not really benefits, but the Medicaid portion should pick up what's not covered by Medicare, provided your provider accepts both.
This is Abby. Can you hear me?
Yes.
Okay, thanks. So going back to the question that was just asked, I have yet to encounter, maybe other people have, but I've yet to encounter a SHIBA caller who knows whether they're plus, like their letters. I've yet to see
Right.
a letter that indicates, there's nowhere it says QMB plus or SLMB plus, unless that's new and I just haven't encountered it yet. How are they supposed to know?
They should get a letter from the community services office on their benefits, because they should be aware that they have a spend down. They should be aware that what their benefit eligibility level is. So, for example, they receive that letter saying you have your income is X amount of dollars over the minimum. You have this much to spend in order to receive Medicaid coverage.
So if the plus, if plus is the plus just something that's internal? Because I guess I'm getting hung up on the wording. Like,
Yeah.
if the letter says spend down, should I assume that they're on a plus? Because it doesn't say QMB plus. I've seen QMB, but doesn't no
Abby,
plus sign.
Abby, what I've seen is they get letters saying that they're eligible for Medicaid.
Okay, and so
That
we
they're-
interpret that as plus.
That QMB plus, the plus is Medicaid, that they have Medicaid as well. Remember, we have those 3 different programs, right? The Medicaid, the MSP, and the extra help. And because they're eligible, they get a letter saying they're eligible for Medicaid, and that makes them QMB plus in the Medicare Savings Program.
Okay, so the plus is just something we use that is used.
It's for the Medicare Savings Program eligibility.
Okay.
It's just another designation.
So I see people who get separate letters saying they're eligible for QMB and they're eligible for Medicaid. So should they get 2 letters stating that fact? One for QMB MSP program, the other saying they have Medicaid?
Good question.
Does anyone know?
I've had the same experience, Kim.
Yeah.
Thank you.
It's probably because it's each program, right? They're going to also get a letter in the mail saying that they have extra help from Social Security.
Yeah, you're
right. And so that's very confusing to folks to get the 2 separate letters.
Yeah.
Well, and this is Abby again. I guess that's what I was trying to get at, is that when we're counseling and we're not in front of them and we have to ask them what kind of letters, it's good to know what they're getting and what so we can ask the right questions. It's not all in one letter then.
Right. Can we get back to spend downs though?
So what's the right question?
Yeah. Don, you've been waiting a long time to ask your questions.
Yeah, I just have to say, I get a lot of calls of people on medical spend downs, wanting to know what they are and how they work and so on and so forth. As far as letters, invariably people aren't aware of it. I just want you to know. And then frankly, all this Medicaid versus not Medicaid and so on, it's totally unclear to the clients. And for us at SHIBA, it's pretty damn unclear too. So I don't know. A lot of times, by the way, these medical spend down clients are referred by DSHS. So it's not like we're seeking them out. They come to our doorstep.
Mm-hmm.
So how do we at SHIBA try to deal with this?
Yeah. That's why we asked them to come here today.
But Noreen, this doesn't help at all. We need written materials and you don't provide it.
Okay. So we're going to work on, Dawn.
Can I ask a question?
Uh-huh. Go ahead.
Oh, I don't know how to use this team, so so when we look at our chart in terms of choices for folks, and it says, it just identifies the plan as dual eligible, doesn't say partial dual eligible. So does, I'm looking at the other chart, the Medicare Advantage from the OIC website that's available to the public. So does everybody with partial dual eligible get to join these dual eligible plans. And then when it says $0 to $35, depending on primary or specialist, that's the copay. When Johnny said the client is responsible for 20%, what can you explain that distinction to me?
Yes, there's I guess I want to make sure I'm covering the right question, because for an individual that's on Medicare, they will have a patient responsibility, and that can be up to 20%. So that would be related to just having Medicare. Now, for a partial dual eligible individual, those individuals are also on the Medicare savings program, and I'll leave Mark to talk to more about that, because I'm thinking that we may need to spend a little bit more time on that piece as well.
We're actually doing that as our February continuing education trainings too.
Okay, excellent. So an individual that is, say, on a specified low Medicare low income Medicare beneficiary, SLMB, or is just a QMB client, qualified Medicaid beneficiary. I think I've got those words wrong. I apologize. Mark can correct me on those, because I'm.
No, we're good. You're close enough.
Qualified individual or a qualified worker with disability, QDWI and QI1. Those are the different classifications of individuals who may be considered partial duals. That means that they have Medicare and they qualify for Medicare by virtue of being on the Medicaid Savings Plan program. Mark, is that all true?
Well, they qualify for Medicare because Social Security says they qualify. We don't get in the middle of that. But they qualify for our program for the QMB, SLIMB, or QI1 because their income is below the whatever the threshold is for each program.
So they qualify by virtue of their income, but they don't qualify for Medicaid because they still are above the Medicaid threshold. Is that correct, Mark?
Yes, correct. Regular Medicaid program is much lower, and the only exception is basically when you're on, receiving a long-term care service and supports. Anyway, different ballgame.
No, please. I think this is I think getting at the heart of what the folks here are asking us, is what differentiates between a partial dual and a full dual eligible individual. Am I correct in hearing that, Noreen?
I think that's part of it, but it's more about partial dual and full dual eligible D-SNP plans. Right. And who's responsible. So what I'd like to do, we have a chart, we call it our D-SNP chart, that it's a side-by-side chart. And we can look at the United Healthcare plans, and maybe we can use this as a visual that you can help us understand who's going to be paying 0 and who's going to be paying 0 to 30% on a plan, because many of the plans have and let me just share my screen really quick here. And I think this is what's really hard to counsel on. I just put up United Healthcare because they go across the screen, right? And we have full and partial dual. I'm not endorsing anything, okay? But we have these ranges. And so this is for partial duals, right? But this one's for QMB, and this one's for full duals. And so what people are having a hard time understanding is we have 50 to 20% coinsurance on this plan. We have 0 to $26.20 a month premium on this plan. Well, who's going to pay the 0 and who's going to pay the $26.20? Are there set? Is it a set eligibility level on different levels of these costs?
Okay, so for your partial dual plan, specifically in the United plans, United has leveraged their administrative dollars to buy down, for some individuals, their premium. There is generally a premium associated with joining a Medicare Advantage plan. But if you are full dual, meaning you have both Medicare and Medicaid, you won't have a premium. If you are partial dual, for the most part, they're buying down your premium, but there may be some categories of individuals who qualify who may have to pay that premium, and that would be dependent upon their level of eligibility.
Okay. So, and whether, just to make sure that we're saying the right thing here, whether they're going to, we can't know if they're going to be paying this premium. So that our answer is you'd need to talk to the company about whether you'd have that 2620 premium or not.
That is correct. That would be dependent upon how they qualify for that plan.
Okay, and the same with the cost, like the co-pays?
Right. Again, for folks that are Medicare eligible, generally they have a 20%, they generally have a 20% patient responsibility. If you are full dual, meaning you have Medicare and Medicaid, both active, then those co-pays, co-insurance, and deductibles are sent to the healthcare authority as part of our responsibility to pay. If you are partial dual, meaning that you only have Medicare and you qualify for one of the SLMB plan, like an SLMB or a QI1, you may have a 20% copay. And that again would be related to, because you have a patient responsibility on that they're not covering for you. Now, for clients again that are QMB, that's a completely different category. They're not quite covered by Medicaid, so they don't have all the Medicaid benefits. Sorry, someone will need to go on mute.
Yep. Thank you.
They qualify for us to pay their co-pays, co-insurance, and deductibles, with the exception of some Part D, but they don't get the full coverage of Medicaid benefits.
Right. Okay. So if someone had QI1 or SLMB and they had a spend down, and they had chosen this plan because they were a partial dual, they had QI1 or SLMB, so they chose this plan, and they had a spend down and they met the spend down, they would be kept on this plan. They wouldn't be able to go to one of the full dual coverage plans, right?
They will maintain coverage under that plan. As part of that plan benefit package. The only difference they would see is that their patient responsibility would be sent to the healthcare authority for payment. Okay.
And then is there a grace period if someone loses their eligibility or their eligibility changes, if they are on let's say they're QMB, and so they have this plan, but then they have a change in income and they lose their benefits. Do they have a grace period to be on that plan, or do they lose their eligibility for this plan, at the end of that month? Or
what you're talking about is called a deeming period. And so under this deeming period, and again, it's will be dependent upon the plan. There are some plans that give you 6 months and some plans that give you 90 days. But if for whatever reason you lose your Medicaid eligibility, not your Medicare, but your Medicaid eligibility, you may have up to between 3 to 6 months, depending on the plan that you join, to maintain coverage as under the D-SNP and to regain your Medicaid coverage. This is different than going from meeting your spend down versus not meeting your spend down. This is where you completely lose Medicaid coverage.
Okay.
Mark, feel free to chime in if I'm misstating anything about the QMB plus issues.
No, I think we're good now.
Okay.
Scott?
Yeah, two things. One, if you go to the HCA automated phone system, I often hear when they give me the benefits, they may say QMB only. Or they may say, I think they'll say QMB, and they might also say full Medicaid. In that scenario, I think what they're telling me that they're a QMB plus because they have QMB and they have full Medicaid. So that's a plus. Now on that chart you were just showing, that really came in handy for me the other day because I had a client who was a QMB. I found out she was a QMB. And then, but she wanted to change her plan. Well, now with the new special enrollment period qualifications or limitations, if she just had a QMB, that's partial Medicaid, and she would not be able to make change. But then I found out through the phone system that she was categorically needy, which would mean that she had full Medicaid, correct? Correct?
Yes.
Yeah, okay, good. And so that meant that, in fact, she now does have the right to make a change, and she could make a change each month. And I believe under the new rules, that's correct.
With the exception, there's some limitations to that.
Go ahead.
So for under the new rules, an individual that is full dual eligible can sign up with one of the full dual plans. During that time, they have a behavioral health services only assigned to the plan assigned to them. So that BHSO, as it's called, is for their Medicaid benefits, specifically their behavioral health Medicaid benefits. So in essence, under the special enrollment period, an individual that wishes to align their care with their BHSO may change monthly, may change that in the month, specifically to align their care. So if they have a BHSO with coordinated care, but they enrolled with United's D-SNP, their full dual D-SNP, then they can make a change to join coordinated care's D-SNP to align their care. Again, the goal is to align their BHSO and their D-SNP. However, an individual that is aligned in a partial dual plan who may not have Medicaid benefits does not have a BHSO. So they cannot align their care. And so once they achieve Medicaid and then they would have to be assigned a partial dual in order for, they would have to be assigned a BHSO in order for any special enrollment periods to take effect. And we have a question out in terms of how that's going to interact with the different plan benefit packages.
Okay.
I think that's above my pay grade.
Yeah. Yeah. We're going to have to find our way with all of this, right?
But keep in mind, a person that is partial dual may have will be partial dual for their review period. So they won't be full. They may not be full dual eligible the entire year. They may only be full dual eligible for a month or two.
Okay. All right. Paul?
On this chart and on the program Extra Help, I believe Extra Help pays the premium for anybody who's partial dual eligible. So the premium line here should be 0 for every plan.
That's for the drug premium. Extra Help only helps with drug coverage. So it reduces if there's a drug premium, then it would reduce that. And we'll talk a little bit about more about that in CE as well. Chris.
Well, actually, two questions back on the extra help. I thought if you had extra help, your maximum cost was $4.20 for a generic and $12 for a brand. And so this $590 is very confusing. And the other thing, my other question is wouldn't you be better off having a regular Medicare Advantage plan where you know that your premium is 0, you know that your primary care doc is 0, and you know that your specialist is $30 or $40? Because when you get into 20%, I don't know who that applies to, and 20% of a big number is much different than 20% of a smaller number. So, when I look at this, I think maybe they'd be better off with a regular Med Advantage plan.
Help me understand that, because I'm not quite certain I'm understanding the where you're going with that. Because again, not all Medicare Advantage plans are built the same. And
no, they're not, but there are Medicare Advantage plans that are zero premium, have zero to see a primary care doctor, and have like $30 or $40. It's a fixed number. You have a budgetable number as opposed to a 20% number. So you might be better off with a different regular Med Advantage plan versus a D-SNP plan. That's my question.
I think that really depends on the client's situation. If the client feels that they can get better resources through paying for a Medicare Advantage plan, and again, not all Medicare Advantage plans are equal. So some will have a 20% copay, some will have other deductibles. There's additional limitations that an individual will have to look at in terms of what their network looks like, what happens if they go out of network, what their care coordination looks like, how that's covered. With these plans, they all have a state Medicaid agency contract, so we have some level of control over ensuring that they provide specific benefits in the state of Washington and that they coordinate better with your plans. So in theory, an individual who goes for a Medicaid covered event that's also covered by Medicare, we expect that plan is going to ensure that any copay, any patient responsibility that comes from that is coordinated with the appropriate Medicaid need. But what you're referencing, because again, if you are a full dual eligible individual, you're not going to have any patient responsibilities. Those are all covered by Medicaid.
Right.
But you're talking about for your partial dual eligible individuals who may have a 20%, then again, that goes down to, we have certain requirements that we have in terms of offering them care coordination, ensuring that we're trying to make sure that they meet minimum standards for coverage, that we have responsibilities for how they do grievance and appeals, and as they coordinate as necessary with other providers to ensure that that client receives the maximum level of coverage. When they get outside of that, then the state Medicaid agency contract no longer applies and they're subject solely to what Medicare has approved. And that again is a limitation from our perspective.
Well, even if you don't have a D-SNP and you have full Medicare and Medicaid, Medicaid's going to pick up literally the balance of your bill, correct?
That's a different discussion. If somebody stays with original Medicare, you only get Medicare, or if you are full dual, you'll get Medicare and what Medicaid covers. So an individual that is full dual that stays in original Medicare will have dental, but they'll have to see a Medicaid contracted dental provider. You'll get hearing, but you'll have to see a Medicaid contracted hearing provider. So that all applies in terms of when you start talking about whether or not they join a dual special needs plan, you'll get things like care coordination. That's not something that's covered by Medicare. You'll get enhanced supplemental benefits, which can include a more open program for dental and vision and hearing. You'll also get over-the-counter medicine covered. You'll get a series of supplemental benefits that go above and beyond what Medicaid currently covers or that Medicare will cover.
Okay, thank you.
All right, Prakash and Aruna.
Do I understand right that partial dual plan does not cover the mental health services, MHSO, and also care coordination?
A partial dual plan will cover what Medicare covers. So if Medicare is covering behavioral health and substance use, which they do, then Medicare is going to pick up that cost, but any additional fee, co-pays, co-insurance, and patient responsibilities would be the patient's responsibility. Additionally, a partial dual plan offers care coordination. But when you're talking about somebody who is original Medicare, there is no care coordination. They don't have access to dental, hearing, and vision, and they wouldn't have access to any Medicaid-covered mental health benefits because they're only in a partial dual plan and not truly Medicaid eligible.
So do I understand that partial dual person would have care coordination
As
And
part of their
same
dual special
behavioral,
needs plan.
right, dual special needs plan. And also they will have behavioral health in terms of mental health and SUD supports, just like Medicare would cover.
Right, because a partial dual plan is required to cover everything that Medicare would cover.
Okay, but how about dental, vision, and hearing? Does the partial dual eligible person gets that all three services also, or no?
Depends on the plan. That's a supplemental benefit that the plan will offer. I think you had that farther down on this sheet, but it really will depend on what plan you're joining and what they're covering. So as you can see for under column N, row 23 there, they cover all $0 for all comprehensive dental services listed below and covered up to the annual plan maximum benefit of $1,000. That's going to be different per plan. Some plans will give you a dental card of up to $1,000 to $2,500, and that's your dental services for the year. Some of them give you $2,000 a card, and that could be dental, vision, and hearing. It just depends on what the plan is offering and those supplemental benefits.
Thank you.
Johnny, do you mind? So I just want to make sure I understand. This is Noreen, I'm sorry. So the people who are full dual eligible, if they had dental needs beyond what their D-SNP plan is offering, they would still get the Medicaid dental coverage for that, right?
That is correct. And we have an expectation in our Medicaid agency contract that if you are in course of treatment with a provider for a Medicaid coverage service, that they're going to help coordinate with a Medicaid covered provider to continue that treatment once you exhaust your card.
Okay. And then, but the partial dual eligible wouldn't have that additional. They're only going to get the dental care that's on their plan because they don't have Medicaid benefits to back up what is available through their D-SNP plan. Right?
That is correct.
Okay. Does everyone follow what I just said?
How does the client verify this coordination or get it started if they have that situation?
They would need to consult with the dentist, let them know that the dentist will let them know, or they can communicate with their plan. We do require their plan to provide that coordination, so they can contact their plan directly and say, hey, I'm getting these services. I don't know that my card is going to cover it. I need your help.
All right, we're going to move on to Abby's question. Prakash and Aruna will come back to you if after we can make sure everyone else gets their questions in. Okay.
Thanks, Noreen. Real quick. So alignment, that word, how we're using align, is that specifically for behavioral health services? Is that where the word alignment comes in? The plan alignment? Is that just for BHSO?
Yes, it really focuses on the behavioral health aspect of things, because here in the state of Washington, we have the BHSO plans. So what we're expecting is that when a client aligns their behavioral health services only plan and their Medicaid and their dual special needs plan, that dual special needs plan is helping them to ensure that Medicare covers what Medicare is supposed to cover, and that they connect and coordinate with the Medicaid side of things to make sure that Medicaid picks up anything that is the client's responsibility. So the expectation would be that because they have one plan providing the full slate of services that wraps around them, their behavioral health and their physical health services, and they're aligned in that, it'll make it easier for them to make sure that they get the coordination they need, and for providers to make sure that they don't have multiple places to be billing. They have more of a one-stop shop to support their needs as well.
Okay, so is it best for the client to consult with their plan to kind of get that plan specific explanation?
Their plan should be able to help them answer any of the questions they may have in terms of aligning their care.
Okay.
So if they are, again, it's entirely at their discretion whether they A, join a Medicare Advantage plan, and B, which plan they join. But
Sure.
our hope is that if they're going to be with the coordinated care BHSO, they look at possibly joining the coordinated care dual special needs plan so that they can have that comprehensive wraparound coverage.
Okay, that leads to my second and last question right now is you mentioned coordinated care special needs plan, but we don't have anything that says coordinate. I haven't seen anything on our D-SNP plans that say coordinated care.
I'm using coordinated care, but their brand name for for Medicare is WellCare. So it makes
Okay,
it,
just wanted to clarify that. Okay.
that part can definitely be confusing because they have a Medicare arm that's WellCare and a Medicaid arm that's coordinated care, but really it's WellCare coordinated care.
Are the provider networks the same?
We have done, we've put in requirements in our state Medicaid agency contract that they align at least 80% of their networks, so that 80% of their Medicaid networks, network that they use to get approval to operate in the state of Washington, but 80% of their Medicaid network also see Medicare clients. So the expectation is that, yes, their networks will be aligned.
We're gonna try to talk a little bit more about that in March too, with the special enrollment period, talking more about those special enrollment periods. Johnny, you're coming back, right, with Vanessa?
I am coming back, yes.
Awesome, thank you.
These
Tina.
are all great questions. I think you're probably hearing a lot from clients, and especially as we're the special enrollment period, but certainly in advance of October, it's good to get these questions out and get they build that knowledge now for muscle memory when we roll into the next open enrollment.
Well, and we get them all along because we have people coming in to it. So, right, we get lots of referrals from DSHS when they have like new people coming into it and things like that. So yeah, we have it to deal with now as well. And people who enrolled during it's the Medicare Advantage open enrollment period, and they're hearing about that and they're like thinking, okay, I want to be able to change my plan. And our question is, can they, when they have D-SNPs, right? So it's good. It is good preparation, but it's not just preparation. It's stuff that many of us can use this week or this month as well. Tina.
I have a couple questions. One is, could an SLMB or say a QI1 qualify for the behavioral health services only? Like if they had a lot of mental health needs? Can we have that combination?
An SLMB would not qualify for a BHSO. They're not fully dual Medicaid eligible.
Oh, they have to be Medicaid eligible to have that. Okay, thanks. And do all the D-SNP plans include care coordination?
Yes, it is an expectation.
And
it's in
what's
their
the practical benefit to the client of care coordination? How does it work, or how do they see that working for them?
Oh, has huge practical use. More often than not, and you probably see this with a lot of individuals who are Medicaid eligible, that they have a doctor who sees them for they have a podiatrist, they have a primary care doctor, they may have an endocrinologist, they may have 4 or 5 different doctors all giving them requirements, giving them medications, giving them expectations and appointments. And so it can become a little bit frustrating and quite a bit of a burden, especially for our senior populations or even families, to try and pull those all together and try and keep everything straight. A care coordinator helps them to, one, access services. So if your primary care provider says, I would like you to see a physical therapist, and you're struggling to find one, they help you access those services. But they also can help you look at what your appointments look like and how they all work together and make sure you're receiving the most efficient care that you need.
Is that an assigned person?
It's more likely going to be an assigned person. You may have a care coordinator that's, they may have a caseload of 50 to 75 people that they're working with, because everybody may need a different level of care coordination. They may have somebody assigned to them that has only 2 or 3 doctors and just needs a check-in once a month or once every 2 months to say, is everything going well? Is everything going smoothly? Do you have any questions about what your providers are telling you? And there may be some that have 5 or 6 doctors that are in the early stages that really need assistance. So the varying levels of what that care coordinator provides is meant to help you access services, help you coordinate those services, and make sure that you're getting your questions answered. So if you have a care coordinator and you're not understanding something, you can reach out to your care coordinator to say, I don't understand why I'm being asked to do this.
How do they, how does a beneficiary know who their care coordinator is? And should we be advising them that they should expect one if they're going to be in a D-SNP plan?
If they want a care coordinator, if they feel like they can benefit from care coordination, they can certainly call the plan to
it's
say,
optional.
right, they're not, everyone can get a care coordinator, but not everyone has to take advantage of it. So it's not like it's, this is your care coordinator, you're forced to use these services. But it doesn't, if you're interested, and if a client has multiple appointments and multiple providers and just things seem a bit overwhelming, they can certainly call the plan to say, hey, I would like a care coordinator to help.
So, and they might like just having someone other than the regular customer service line to call when they had questions. But how do they get one? How do they ask for one?
They call the plan and request one.
Okay, so we could advise people that you might like to do this. If you're enrolling in this plan, you might want to get a contact person to help you use your plan.
Yep.
Great. Thanks. We'll do that.
All right, Eva.
Someone earlier said that much of this is above their pay grade. I agree. And my question is, we're going to run into a whole bunch of people who have questions that are just, we don't know how to answer those questions. Who do we refer them to?
So you're talking about what type of questions? So I want to make sure I'm answering the right question, the directing the right.
Medicaid related questions.
If they're looking to understand more about the Medicare Advantage that they've signed up in, then I would refer people back to the Medicare Advantage plan that they've joined. They should also be able to help with most of the questions that you're probably hearing from. Now, if you have any questions about Medicaid and how Medicaid itself, Mark, would you say that would be the HCA call center?
Most often, at least starting point.
Yep.
And things like spend downs, it would go to DSHS, right?
That would be their community services office.
Okay. Noreen, if we're confused about who to send people to, is there somebody at OIC we can get to direct traffic?
I think that's me right now.
Lucky you. Okay.
Yeah.
Okay, thank you.
We're in the process of working on this, of trying to kind of break things up, right? Because we have all those new RTCs. We have a lot of new staff, but I think it's me for right now. And then honestly, I half the time send a message to Mark and Vanessa and Johnny on Teams and say, help me, help me.
Yeah, but I'm thinking that Mark and Johnny and Vanessa aren't that interested in hearing from all the SHIBA counselors directly,
So,
right?
Yeah, so I'm the primary point of contact for right now.
Okay.
Yep. Feel free to send me your questions about D-SNPs. Feel free to send them to me, or counseling for D-SNPs. Like, do I need to do this? Okay.
Thank you.
Maureen. Maureen, did you still have a question?
Yes, I'm sorry. I'm not familiar with Teams yet. On the Medicare Advantage chart that we give to folks that is available on the OIC website, it'll say, for example, on these D-SNPs, the annual drug deductible. I'm confused about why there would be a drug deductible on a D-SNP, because those folks would be LIS. That's question one. And then I'd like to get a sense of an example on the question of alignment. just, naming a plan for a BSO, naming a plan for a Medicare Advantage plan, and how that alignment might work in an example. And then my third question is there someone monitoring this care coordinator option for folks?
Okay, let's save the alignment question for last, because we're down to our last few minutes, and we're going to talk more about alignment in March, if that's okay. We can bring it back up at the end if we have time, but.
Well, I do have a hard stop at noon, so I
Right.
apologize.
Yep, nope, it's okay.
Maureen, let me pick up the care coordination piece, but each plan has to submit what's called a model of care to CMS, and also we take a look at that as well. That's how they're going to deliver the services. So they get monitored not just by the state of Washington, but also CMS to ensure they're adhering to their model of care. We receive concerns and we track those, and so we certainly follow up with the plans as we hear concerns if clients are struggling to access services. So that, in that respect, we are certainly expecting they're going to hold to the contracted terms that we've set up for them.
Do we have access to that model of care for the plans?
Do you have I don't know if it's made public or not. It should be, but I'm not certain. I can't think of off the top of my head where it's at, but certainly I can take that back to find out if there's if that's public. But certainly it's very clinical, but certainly I think it should be public.
Okay. So Johnny, you need to go, right?
I do. Thank you.
Okay. Thank you so much for joining us. We really appreciate it. And thank you for being willing to help us next month as well, which is kind of an extension of this, right? Mark, did you need to take off too? Or can you hang around a little bit and see if there's questions that you can?
I can hang around for a few.
Okay. Let's
This is
give
the
it.
interpreter speaking, though. I have to go as well.
All
Sorry.
right. Thank you. So Maureen, I think are we done? For you?
Oh, sorry. Did I not put my hand down? Sorry.
Yeah, no, it's okay. We're all adjusting to teams, right? I just want to make sure that we're good for you. Connie, you're next.
I don't think you answered the question about the deductible and LIS. That she asked.
Mark, can you explain why some of the D-SNP plans show that it has the Part D deductible when people would have extra help that covers that mitigates that?
Yeah, I can't address that.
Okay.
That'll be a Johnny question. I imagine if the stars align and everything, they're all in the same network or whatever, then it gets covered, but.
Right. And they would all have extra help. So, which means that negates their deductible. So who knows, maybe it's there for the same reason as the maximum out of pocket when they really don't have costs for most of these plans, right? Because it has to be there because it's a technicality. I don't know. Who's next? Connie, did you have another question or did you just want to bring that up? All right. Prakash and Aruna, go ahead.
Thank you for a very informative presentation. My question was, when the same provider health plan like UHC has multiple D-SNP plans, how do providers figure out which plan a consumer has? And what are the services that will be available, the person would be eligible for? How does provider figure out all this multiple plans by the same insurance company?
That's not our problem.
Well, that would be the same as any multiple insurance plans from a company, right? That they have a variety of plans. It's going to depend on their plan number. And sometimes we'll see that providers will accept certain plans, but they won't accept other plans. Especially in our smaller areas, we have providers who are they're in network for the D-SNP plans, but they're not in network for standard plans, for standard MA plans and things like that. So it has to do with that plan number and whether they're in network for the plan for that particular plan, not just the provider. I'm sorry, not just the company offering the plans.
Thank you.
Who else do we have? Do we have anyone else? All right. Looks like that's it. Mark, thank you for your time. Viva, thank you for joining us as well. And we really appreciate everything that you've said. I have recorded today's session. That'll be
Yeah, thanks for inviting us.
Yeah, thank you. And I have a presentation that Mark sent me. If you weren't here, like a little bit early, I have a presentation Mark sent me that I'm going to share in the follow-up email to today's session as an attachment. And it's on spend downs and the qualifications and all those things that Vanessa kind of explained. I'm sorry, that Angie explained to us last month is in a PowerPoint. Okay, it does include information for programs that we don't deal with, like for spend downs for people who are on Magi Medicaid, right? And those people are people without Medicare. So just ignore those parts. You just want to look at the parts that are for people with Medicare. Okay. But and what I'll try to do is I'm going to make a note of the slides that you can ignore. And so I'm just going to send it out to anyone who attended today. And then I have a couple of people who called me that said that they couldn't attend. That being said, if you have someone who isn't here, if you have someone in your organization that didn't make it today and you think that they would like the information, please feel free to send me their name or have them send me their name and their email, and I'll be able to send it out to them. Right. Okay. Anyone else have anything that they'd like to share for the good of the order? How many people are more confused? Yeah, it's confusing. But
I think care coordination information is really vital to this population, and learning more about it and alerting the consumers to that would be a big, I think, helpful thing for the consumers.
Yeah, one of the things that we are going to try to do is get in a couple care coordinators that they can explain what they do and how they do it. Yep. They work for the private companies though, right? Or they're contractors. So they're a little bit harder to track down and to just have as an authoritative source. Connie. Connie, did you have something? Connie, did you have something to add? Your hand is up.
Looks like an office.
Okay. All right. Well, thank you, everybody. And I'll be sending out the follow-up email today or tomorrow, and all will be well, hopefully. We'll see you all next month or at CEs.
Thank you. Bye-bye.
Thanks.
Bye.
Bye.